I now have the pleasure to introduce our speaker for this week. Dr. Justine Welsh is a child and adolescent and adult addiction psychiatrist at Emory's Department of Psychiatry and Behavioral Sciences and the founder and director of the Emory Healthcare Addiction Services. She's also medical director of the Addiction Alliance of Georgia, a collaborative between Emory and the Hazelden Betty Ford Foundation, developed to expand addiction-related clinical, research, and educational services across Georgia. Dr. Welsh's research has focused on evidence-based treatment for adolescents and young adults with substance use disorders. She's been the recipient of award and grant funding from the National Institute on Drug Abuse, American Academy of Child and Adolescent Psychiatry, and National Center for Advancing Translational Sciences. Dr. Welsh is an active advocate for enhancing access to quality comprehensive treatment for individuals with substance use disorders. She currently serves as a board member of Georgia's Department of Behavioral Health and Developmental Disabilities, and on a national level co-chairs the Public Policy Committee for the American Academy of Addiction Psychiatry. Dr. Welsh also serves as an expert consultant to the Center of Disease Control, focusing on reducing addiction-related stigma and enhancing medical education. So we extend a warm welcome, including my cat. If you heard him meowing, I apologize about that, to welcome you to our session today.
Loved it, Chris. Thank you so much. I'm going to go ahead and I'll share my screen now. All right, so jumping right in, a couple kind of housekeeping slides here. Here's my financial disclosure. I don't have any relevant financial relationships to disclose in the past 24 months for this talk. So practice gaps and supporting resources. What I really want to be highlighting today is that the current guidelines recommend the use of medication for opioid use disorder, or MOUD, in youth, but this is not being commonly used in clinical practice. So hopefully we will be changing that today. So my learning objectives, I'd like everybody to be able to better describe the supporting evidence for the use of medication in youth, to appropriately utilize behavioral treatments for opioid use disorder, and then also to identify some of those risk factors that can contribute to opioid use among youth. I would also like participants to be able to identify those key differences when you're evaluating and treating patients, both adolescents, young adults as compared to adults, and then also to really be able to take home and educate other community members about the importance of providing care to this patient population. So opioid use disorder in youth, and I commented to Chris that all of a sudden my slides looked really dark and negative, but I do want to highlight that working with this patient population is incredibly rewarding, and something that I just really love doing. So let's go ahead and jump in. Here, my disclosure slide. I don't believe any of this actually presents a conflict of interest, but it is all of the areas that I receive funding, including from the NIH and then my own employer. So before we get into the outline, I do want to just announce that I am getting over a non-COVID related viral URI. Apparently those do still exist. And so I apologize if my voice is going in and out. Please chat me if for some reason you can't hear me, and I'll try to drink some water for you. But our outline for today is going to be focusing on the definition of youth and how that applies to the data that we do have, epidemiology, risk factors, how to screen individuals for opioid use, particularly in this age group, and then what are the existing treatment strategies. So again, those take-home points, if you didn't hear them the first time, medication for opioid use disorder should be used in adolescents and young adults, and that there is a need to advocate for the use of evidence-based treatments in this patient population. So let's start with that definition of youth. It's really important to clarify who we're talking about when I present the data on treatment, because there are some similarities as well as major differences in how we approach treatment in these various age groups. Now, youth is more commonly being used as a catch-all in the literature. Many of our studies actually lump together both adolescents and young adults, which is why I'm focusing on the word youth for the talk instead of just adolescents. There really isn't any consistency in how it's defined. Many of the studies I'll be presenting here have variable age groups like 13 to 18 or 15 to 21 or even 11 to 24. These age ranges can have a dramatic difference in how you apply the data. Most of the slides I'm using are in reference to under the age of 18, unless they're specifically stated. But keep in mind that individuals may have greater efficacy who are older than 18 with the medications that are used more commonly in adults. So let's see here. Age certainly plays a role in treatment, especially in things like family involvement and limit setting. So for example, limiting access to money to purchase substances in a 15-year-old tends to be easier than a 24-year-old. But I also want to focus on the developmental time period a patient presents, which can represent both maturity, but also where they are in terms of brain maturation. So here you see an illustration of the relationship between the area of the brain called the prefrontal cortex, or the PFC, and the striatum, or the reward center, which contains the nucleus accumbens. And these are represented as both hot and cold spots. So activation in these areas is relatively equal in childhood, but during adolescence, the reward centers become particularly active prior to the full maturation of the prefrontal cortex, which is actually the top-down control that tells someone to think through their actions and consider the long-term consequences. Hence, this is a really high-risk period of time for substance and opioid use. Then in adulthood, the two become more evenly matched again, or at least we're hoping that they do. But this is one of the reasons that things like untreated ADHD is a risk factor for substance use. So ADHD really impacts the ability of the prefrontal cortex to fully function. So if you don't have that top-down control, the reward center remains mismatched and you're at a higher risk of substance use across the board, including opioids. Now let's take a look at epidemiology. I'm going to spend a little bit of time on this topic because I feel like it's really important for people to understand the extent of the problem. So here's a figure from the National Survey on Drug Use and Health, which collects data on over 70,000 individuals each year here in the United States. It's a home-based survey that's also rich in patient-level demographic information. I really like that it's a home-based survey and not necessarily a school-based survey for capturing data on adolescents, because you tend to see adolescent patients with more severe substance use disorders, including opioid use disorders, not being present in school because they're either in treatment programs or they're truant or they're suspended, whatever it may be. So this is a home-based survey. And here you're looking at the past year pain reliever misuse. And it's broken down into the age groups of 12 and older, 12 to 17, and 18 to 25, and 26 plus. And you can see that there's been a decreasing trend in opioid use over the last few years, with the 18 to 25-year-olds having the highest rates of use, which is across the board the same for pretty much every substance in this age group. And those 12 to 17 have about a 3% area of misuse in the last year. The dots aren't connected between 2019 and 2020. For those of you who are familiar with the DSM or our diagnostic manual, it's switched from DSM-4 to DSM-5, so they can't do a direct comparison in years there. But all of this is freely available data online. So this here is a reflection of that full DSM criteria. Here we're looking at DSM-4 criteria. And you can see that the adolescents hover at about 0.5% for having a past year opioid use disorder, while the young adults have been trending downward, but they're now at about 1%. And these, again, are national estimates, so they can differ a bit by state. So why do we care if these numbers are so insignificant on those previous slides? Well, it's partly because of how lethal opioids can be. Despite decreasing trends in the diagnosis of opioid use disorder, we've actually been seeing a significant rising mortality in youth. So here you can see that the overall proportion of deaths in 15 to 24-year-olds secondary to opioids was 2.9% in 2001. And by 2016, opioids were responsible for about 12.4% of deaths. Unfortunately, access to care for adolescents and young adults is very delayed. So unfortunately, even after surviving a diagnosed overdose event where you presented for treatment, and often people don't present for treatment or medical assessment through an emergency room, only 1 in 54 individuals receive medication in this age group. And only about 5% of adolescents receive medication within a 3-month time frame of being diagnosed with an actual opioid use disorder. And that's compared to about 27% of young adults. Here's that number in the thousands of opioid-related overdose deaths in the 15 to 24-year-old age group, and that's trending through 2020. And it's really just continuing to dramatically increase, hitting about 6,000 individuals in the US in 2020 alone. And this is data from the CDC. And please stop me if anybody has any questions. This here is a figure, and it's also demonstrating that adolescents are combining opioids with other things, particularly benzodiazepines or stimulants, and that the trend in overdose deaths mimics that of opioids plus a substance mimics that of opioids alone. So you can see in that 13 to 25-year-old age group that deaths secondary to opioids alone increased by about 384%. And this is from 1999 to 2018. But then it actually increased by 760% for opioids plus additional substances. So many of our patients are presenting having used multiple substances following an overdose event. So one strategy to mitigate risk is to mitigate exposure and to manage exposure. So the majority of people don't obtain prescription pain relievers from drug dealers. They're actually most often obtained from a prescription or given by or bought from or took from a friend or relative for free. So you can see there that the obtaining it from a friend or relative is about 47.2%. So this pie chart shows the source where pain relievers were obtained for the most recent episode of misuse in individuals 12 and older. Again, this is data from the National Survey of Drug Use and Health and is freely available online. So opioid prescriptions are still in circulation across the US. So let's take a little deeper look at some of those risk factors for substance use, especially in younger patient populations. And those include genetics, exposure, and then some of the psychosocial factors. And these all have different influences on substance use and opioid use, such as the age of initiation, so how early someone begins to use, whether or not that first use progresses to an actual substance use disorder diagnosis, and then the associated risk behaviors that can present alongside substance use. So this slide is an oldie but goodie, and it's demonstrating how heritable substance use disorders really are by the type of substance. So here on the right, you see a measure of heritability by substance in twins, and it's ranging from about 0.4 for hallucinogens to about 0.7 for opioids. So the way that we determine genetic risk has come a long way since 2005, which is when this was published in Nature. But it still demonstrates a significant connection between substance use and heritability, where approximately 50% of the risk across the board is genetic. Most of the risk factors for substance aren't necessarily specific to any one drug, but they can apply to most of them. Here, though, this is very specific to opioid use. And so the existing evidence on risk factors for non-medical opioid use or developing an opioid use disorder after what we call short-term therapeutic exposure, so an opioid prescription for a legitimate pain reason, is unclear. So this is a little bit hard to read, but what I really wanted to do is reflect that the potential risk factors have been identified, but they're really inconsistent across the literature for someone converting to non-medical or opioid misuse from a legitimate opioid prescription, and this is in children. And you can see that they've looked for things like age of exposure, sex, race, ethnicity, also coming from things like a two-parent household or a parent with a college degree, and then also types of injury. So was this an acute injury? Were you hospitalized? What was the type of opioid? So it's a really interesting summary here, review article, and I'm happy to send it to anyone if you guys want to email me. So here you can see some of the psychosocial factors, and many of them just kind of make sense from a developmental and a cultural standpoint. And they include things like family alcohol and drug behavior attitudes alongside parental substance use. So genetics aside, if you have parents who misuse opioids or any type of substance, their offspring are more likely to also misuse substances. So I've seen plenty of parents who are presenting with opioid use disorder, and then unfortunately their adolescent child or young adult is presenting with an opioid use disorder. I've also seen it across the board with other forms of substance use, from alcohol to nicotine. I had a parent and a patient present just last week, and the parent was an active smoker and the adolescent was an active smoker. And so a significant portion of the intervention is really just to quit, to get the parent to commit to quitting versus that adolescent, because without that, the chance of success is just greatly diminished. We've also identified risk factors for adolescent substance use, such as early onset of aggression, neglectful parenting, and unsupervised time. So when thinking about the highest risk period for substance use for an adolescent, people often think about the weekend or a Friday night, but actually it's right after school, before parents get home from work, that adolescents are using substances most frequently. But again, I want to reiterate that these are only risk factors. Parents may feel like their child's addiction is their fault. And honestly, I treat some patients with just incredibly low identifiable risk, where I can't even guide on any type of different parenting practices that would have slowed the onset of an addictive disorder. I just want to briefly mention that many of these adolescents also have co-occurring psychiatric disorders. I previously did some work with the outpatient substance use disorder program at Boston Children's Hospital in Massachusetts. We used a data set of 483 individuals, and they were ages 11 to 24 because that's who they treated at that clinic. 133 of those had an opioid use disorder or problematic opioid use. We then examined whether or not the type of substance use disorder was more likely to be associated with a specific mental health diagnosis. And here you can see that in our sample, individuals who predominantly used opioids were anxiety disorder as compared to the adolescents who primarily used non-opioid substances. So you can see a significant association between opioid use and anxiety disorders, at least by this study that we conducted. And some of this has been replicated in the adult literature. I wanted to take a quick moment to reflect on some of the challenges brought on by the pandemic in this patient population. So early life stress, social isolation, and boredom are known risk factors for the development of both depression and substance use in youth. We've also seen a negative impact on protective factors like connection with the school environment and an individual's community. What people often don't think about is that an estimated 1 in 8 US children aged 17 and younger already live in a household where at least one parent has an active substance use disorder, which equals about 8.7 million youth. Again, going back to that goal slide, we need to do a better job in addressing adolescent substance use, and that includes screening the whole family when parents present to their treatment, whether it be for substance use disorder or even for general psychiatric conditions. Those parents have also been impacted by the pandemic. Again, it's not unusual for my own clinic to be providing care to both child and parent, and to identify that sometimes it can be the parent's substance use that can be a barrier to the child achieving abstinence themselves. But of course, that is not always the case. And I see plenty of patients in my clinic who are not coming from families that have active substance use and who come from very supportive families and present families. There are also a number of telehealth challenges, including difficulty with lab monitoring, such as urine drug screens. There can also be an avoidance of treatment. For adolescents who've been really angry about coming to my office before, I would actually have their parents take their cell phones, and we would just sit there together until someone decided to speak. But now with a computer, patients will be doing other things, and that strategy is just way less effective. There is also potential breaches in privacy when providing telehealth to adolescents, where parents or patients are really worried that their parents are going to overhear. So I've had many a strange telehealth session where for privacy, an adolescent will be sitting in a bathroom because they just can't find another place where they feel safe in talking about some of the substance use or behaviors that they've been engaging in. So I do see a question here in the chat. Will the data results on the generalized anxiety disorder correlation and OUD be because of the type of treatments prescribed for generalized anxiety disorder? So that's a good question. I'm wondering if the thought there would be maybe benzodiazepines or controlled substances being co-prescribed for generalized anxiety disorder. You know, we don't really know the mechanism underlying the association at this point. It's kind of a chicken or the egg. So it could be that patients who have anxiety are more likely to seek out opioids, or at least to return to use or have a perpetuation of opioid use. It could also be converse, that there's a greater risk in the other direction. I don't know so much that it would be the treatments prescribed for generalized anxiety disorder. In my own clinic, I've heard time and time again patients presenting with opioid use disorder who just describe this kind of overall sense of relief the first time they tried an opioid, whether it be that they had used it for a legitimate pain purpose and it was prescribed. I've seen kids presenting in my office who started using opioids after wisdom teeth extractions. That's actually been a big one. They've been getting them from dentists. And then once they're exposed, they just describe that their anxiety is just relieved, and they just, they're looking for that relief after that point. And then of course it perpetuates into problematic use. And then unfortunately, sometimes opioid use disorder. So let's see. Most studies looking at the association of mood and ADHD symptoms, development of OUD, suggest that adequately treating those symptoms with medication. Absolutely. So Devin, you wrote that. Absolutely. ADHD is a significant risk factor. And so there's been an apprehension to prescribe controlled substances, specifically stimulants, to patients with ADHD, but we now have a substantial amount of data that demonstrates untreated ADHD increases the risk of substance use disorder, including opioid use disorder, and that aggressively treating those symptoms actually decreases it, even if you're aggressively treating it with controlled substances. And the next question, if we have studies and data that show that relationship, then would it not be better to not be treating GAD with benzos? So I am not aware of any actual data that demonstrates treating GAD with benzodiazepines increases the risk of opioid use disorder. Certainly, I'm incredibly apprehensive of treating GAD with benzos, and I go for first-line therapies like SSRIs or antidepressant medication, and then go from there. A benzodiazepine, from my perspective, is a last resort, especially in adolescent patient populations, just because of the risk of addiction with benzodiazepines and then physiologic dependence the longer that you are on those medications. Of course, there can always be exceptions to that rule. So say a patient is presenting with a co-occurring bipolar disorder and they are acutely manic, then benzodiazepines may be indicated as a short-term therapy in those types of patients. But they're not typically my first line for anyone with GAD. But great dialogue here. So just jumping back into some of these risk factors, and we'll go a little bit more into some of the treatment aspects later in this talk. I wanted to use this figure just to quickly highlight some of those risk factors in relation to the pandemic for substance use, because I suspect that we are going to continue to see increases of SUDs in adolescents across the board, partly in relation to the pandemic and the psychosocial and behavioral changes that everybody experienced because of it. So here you're looking at data from the Adolescent Brain Cognitive Development Study, or the ABCD, which was already in place pre-pandemic. And so you have data from about 7,000 youth ages 10 to 14 who completed different assessments of substance use throughout the course of the pandemic. And what they found was varying degrees of correlation between some of these risk factors and an increase in substance use in that adolescent. But I want to highlight that this is not opioid specific. It was across the board. They didn't call out specific substances. Interestingly enough, attending school in person was actually a risk factor for substance use. And I think it was likely because of increased access. And so again, we're still trying to tease out what were those protective factors in the pandemic, what were those risk factors. And I think we'll know more as we get further out. So moving on to screening. The American Academy of Pediatrics actually recommends annual substance use screening beginning at the age of 11. Screens should be very age appropriate, and I have an example of one here coming up later in this talk. Things like the cage, which is used for alcohol, is not an appropriate tool in this age group. Before doing any screening, though, a clear conversation about confidentiality should be taken place prior to collecting any data, especially from a minor. I wouldn't even want to collect screening information in the waiting room before talking about what is going to be done with it and what information is potentially going to be disclosed to their parents. So the last thing you want to do is surprise an adolescent by sharing their responses with their parent when a safety issue arises and they didn't know you were going to do that. You can assume that taking that type of approach will just develop a degree of mistrust in the treatment system for that patient that could potentially be lifelong. So circling back to some of my goals here, I really want to have people also realize that involving families in treatment is incredibly important. But again, before you do, explanation of confidentiality and what it means is necessary. So when talking about confidentiality, I add in areas specific to substance use when doing my typical speech about safety in areas of disclosure. So when an adolescent or minor patient is presenting to my office, they need to understand what information could potentially be shared with their parent or their guardian. So I will talk about the use of urine drug screens. I let the parents and patient in my own clinic know that diagnoses and lab results, including urine drug screens, will not be withheld, whereas treatment notes and information disclosed in treatment will be. I also mentioned very specific safety concerns in relation to substance and opioid use, such as transition to injection drug use when someone has not been already using IV substances. Ongoing use of opioids or opioids in an opioid naive patient, to me, can be a safety risk, and I need to assess the risk of overdose, which again goes to safety. And then I also talk about driving while impaired, and this can be on any substance, opioids, cannabis, etc. I do consider using cannabis while operating a vehicle being impaired, although plenty of my patients will disagree with me on that. I also want to really highlight the TAY, transitional age youth. That's your 18 to 25-year-olds here, because confidentiality in this age group can be particularly tricky. You may be treating an 18-year-old or working with an 18-year-old who is still in high school, so they're very tied to their family, but they are legally an adult. And in these cases, I do what I like to call a waiting room invite. So when I'm in person, I will walk to the waiting room and I ask everyone that was brought to my office to come back to my office for an orientation to the clinic, and I call it an orientation. That typically avoids confrontation in the waiting room of that young adult telling the parents or guardians to stay back. It then gives me the opportunity to introduce myself, what I do, and what treatment can look like, including confidentiality. I then review in detail the variations of confidentiality, such as not having consent at all, as well as partial consent. I also let the parent know that if all of a sudden I stop returning their phone calls and our front desk no longer speaks with them, to assume that consent has been revoked, and that they should speak with their child or their young adult about allowing them to be part of the treatment process again. And I have learned this one by unfortunate experience, where parents assume treatment is going really well or that their young adult is adherent to medication because they haven't heard from me, but really the consent has just been revoked, and I have been unable to get in touch with that family to let them know my concerns. So here's an example of a screening and assessment tool that I'd mentioned that is freely available online. This is called the CRAFT. And again, there are multiple screening scales that can screen for a variety of substances, including opioids. CRAFT is just one of them. Another one that I wasn't able to include in the talk is called the S2BI, Screening to Brief Intervention, which can be applied to adolescents. Again, freely available online. You can find some of these either by Googling them or going to the NIDA website and looking for screening scales, so the National Institute on Drug Abuse. So one thing I really like about the CRAFT is that it gives a nice little bar graph at the end that includes the likelihood of having any type of substance use disorder, of course, applicable to the substance that they screened positive for. It also now integrates a validated screening tool for tobacco and vaping that I really like. And I find across the board, probably 95% of my patients are engaged in vaping, whether it be nicotine or THC or other substances. So I do screen every patient I see for vaping, which can be, unfortunately, sometimes hard and difficult to quantify. Great, thanks, Chris, for putting that in the chat. So again, at the end of the screen scale, and you can't see the third page, it does give a bar graph, which sometimes I will use that as providing the feedback for the family without disclosing any of the specific details about the actual substance use that the patient provided to me. So moving on to treatment, and before I do, does anyone have any questions? You can feel free to unmute yourself or put them in the chat. Please feel free to stop and we can have this be more interactive, or I can just go through the slides as well. But moving on to medication. So let's take a look at the 3 FDA-approved medications for opioid use disorder. And it's my understanding that there have been different presentations focusing on these medications for their use in adults. So I'm not going to spend much time on that data. But again, those include methadone, buprenorphine, and naltrexone. And here's a statement that I feel really strongly about, that all patients with opioid use disorder should be offered maintenance medication, and that's because of the risk of a return to use, overdose death, and other negative associated outcomes, including hepatitis C and endocarditis. pericarditis. And patients should not be excluded from this statement based on age alone. So despite access to MOUD, as well as naloxone, opioid-related deaths are just continuing to increase in this age group, as we saw. And unfortunately, the vast majority of youth, both adolescents and young adults, entering treatment for opioid use disorder are not provided medication, including buprenorphine, even though it's FDA indicated for ages 16 and older, and that's FDA approved. Here you're kind of looking at a table that has outcomes from both adolescents and then adults. And so what we have found across the board is that patients who receive medication for opioid use disorder, or MOUD, are 3 times more likely to remain in treatment at 3 months follow-up compared to patients receiving just detox. And you can see in this table here from a Connery, Dr. Hilary Connery's paper review article, the opioid abstinence rates when compared to patients receiving medication versus not receiving medication. And the Woody et al. Study we'll take a quick look at, but you can see that that study was in adolescents and young adults, and 60% were opioid free on medication versus 20% without medication. So the literature that we have in adolescents mimics that of adults as far as abstinence from opioids, at least in the short term. So let's focus on some of that data that we do have. I want to highlight that the American Academy of Pediatrics does support the use of medication in adolescents with opioid use disorders. And this is a snippet of their policy statement supporting it. So let's start with buprenorphine. Buprenorphine, just to refresh the memory, is a partial opioid agonist, FDA approved for the treatment of opioid use disorder. And it's actually the only addiction medication FDA approved for adolescents. We do not have any FDA approved medications for substance use disorder in anyone under the age of 18, except buprenorphine for opioid use disorder. We don't even have FDA approval for nicotine treatment or nicotine replacement in minors. So again, that's kind of just emphasizing that we have a substantial amount of both safety and efficacy data for the use of medications, at least in 16 and older. And our data actually goes younger than that. So buprenorphine, this here is that sentinel study by Woody et al. That I had just mentioned in 2008, and it really helped gain the approval for maintenance use of buprenorphine in this population. And you can see on this slide here that the buprenorphine group versus detox alone, so patients were they had opioid use disorder and then they were detoxified versus being maintained on buprenorphine out through a 12-week period. They had less opioid use, less injection drug use, and higher treatment retention throughout the 12 weeks. And it really helped to support maintenance therapy and not just tapering patients off buprenorphine once they presented to treatment. Unfortunately, one of the challenges that we have is retaining younger patients on buprenorphine or on any type of medication for that matter. So rates of retention out through 1 year are ridiculously low. So this study was looking at adolescents, young adults, ages 15 to 24, had 103 participants. And in this clinic, those who were receiving buprenorphine were only retained at about 9% out through the 12-month period. So again, rates of treatment retention on medication for opioid use disorder in adolescents and young adults is significantly lower than for older adults. And it's really just indicating a need for us to do research about how to retain these patients and engage them in treatment, because we know medication works, we just don't know how to keep them on it. So here's data for naltrexone, so the extended release once monthly injectable, also known by the trade name Vivitrol. It's off-label for the use of this medication in anyone under the age of 18. I still use it. And surprisingly, I actually have not had any pushback from at least private insurance in using naltrexone extended release in patients ages 16 and 17. I have not had anyone age 15 or younger on this medication, but I certainly do use it in my older adolescents. The data, however, is based mostly off case reports, but there was one recently published here in 2021, a larger randomized trial of over 288 individuals, adolescents and young adults ages 15 to 21. But unfortunately, at the 6-month mark, only 2 out of the 82 people randomized to naltrexone actually received all of the doses. So again, treatment retention on medication in this age group is absurdly, absurdly low. Those who did receive naltrexone had lower rates of opioid use, but you couldn't really achieve statistical significance because of such high rates of dropout. For methadone, which is the third FDA-approved medication for opioid use disorder in adults, it's been used for decades in adolescents. Most of our data actually comes from the 1970s and 80s, but there are no controlled studies. And here in the US, an adolescent must have failed other treatments first, at least 2 other attempts at treatment, including abstinence-based treatment, so not using any medication. I've honestly never seen anyone in this age group admitted to a methadone clinic. So it's really just not commonly used. And of course, adolescents would have to go to a federally regulated methadone clinic to receive it. Here in opioid withdrawal, I've seen at least in our local Children's Hospital of Atlanta, patients presenting in opioid withdrawal, at least to the medical units, typically are not receiving buprenorphine. They're receiving supportive management like clonidine. So basically medications that are just used to treat some of the symptoms, but they don't do a very good job at it. But we do have some supporting data saying that the use of buprenorphine over clonidine is preferred in minors. And so this was a study looking at individuals ages 13 to 18. And what I really liked about this study is that the patients were actually tapered off buprenorphine and then switched to naltrexone, the opioid antagonist, as the end goal. So buprenorphine was literally just being used for detox in this study. But the buprenorphine group had a 61% successful conversion rate to naltrexone, the opioid antagonist, while the clonidine group only had 5% of its participants converted to some type of maintenance treatment. So here, even the use of buprenorphine in a detox setting helps retain patients in care, even if it's not the long-term goal and you're switching to something else like naltrexone. So just wanted to highlight that here. Please also give out naloxone to anyone who uses opioids or even someone who has used a variety of substances. I give out naloxone in my clinic like it is candy. It is FDA approved for use in all pediatric populations. So you can prescribe naloxone to a 12-year-old and you're not going to get pushback at the pharmacy. Here in Georgia, patients don't need a prescription for it, but I do often send it home with parents and encourage them to get it filled. Again, going back to that slide of 12.4% of deaths in the 15 to 24-year-old age group are attributable to opioids. I have had plenty of patients who have never endorsed opioid use, but screening positive for opioids on urine drug screens. They don't know that they're ingesting substances that are laced with opioids. I've had patients overdose after smoking just what they thought was cannabis, but it ended up being laced with fentanyl. So I really try to educate my patients to have naloxone, even if they've never endorsed a history of opioid use, if they're going to be at a party, if they are using substances that they don't know necessarily where they came from or what they are. I give naloxone and recommend naloxone to everybody I see. And a lot of that comes with education for the parents about the importance that if it's not for their child, think about another child who may be presenting to their household who could have ingested something or brought something with them.
Dr. Welch, just before moving on, I did have just a direct message to me. Can you speak a little bit more and explain what clonidine is, and just what the comfort medications are, how they're different from, buprenorphine, for instance?
Yeah, no, that's a great question. So clonidine is what we call an alpha-2 agonist. So it's used as a blood pressure agent, and then also more off-label and also used in ADHD to kind of dampen down what we call the noradrenergic overdrive in patients with ADHD. It's used in treatment of opioid withdrawal specifically because when a patient has opioid withdrawal, their noradrenergic, so norepinephrine system kind of goes into overdrive. And with the norepinephrine, it causes symptoms of restlessness, hyperarousal, anxiety. And so clonidine can be used to counteract some of those symptoms. And when I say supportive care, you're also often using medications that will decrease a person's diarrhea or nausea, some of those characteristic symptoms that you can get with opioid withdrawal. So clonidine can help decrease some of those symptoms. But if you've ever worked or treated a patient in opioid withdrawal, using clonidine alone does not take care of all of the symptoms that they're experiencing. And so buprenorphine, being a partial opioid agonist, binds to those mu opioid receptors in the central nervous system. And what it does is it partially activates them. So about actually 40% compared to a full opioid agonist, which would do it at about 100%. And when it binds to those receptors, it does it in a very controlled fashion to decrease not only symptoms of opioid withdrawal, but also cravings for opioids. And so my suspicion here is that the reason buprenorphine did so much better than clonidine is that clonidine was not only not fully addressing symptoms of opioid withdrawal, it also wasn't helping to suppress cravings for opioids, which, as people know, dramatically go up during opioid withdrawal. And so then you have a return to use versus a willingness to engage in treatment because of opioid withdrawal and ongoing cravings. So I'm not sure if that answered that, but I'm happy to go into that a little bit deeper if you guys want to put anything in the chat, or Chris.
That's great. Would you mind? I'm actually for the receptor, re-mentioning the receptor that you said that worked on. That was one of the questions that came back, and I missed it. That clonidine works on.
So clonidine works in the noradrenergic system, and it works to decrease overall levels of norepinephrine, which is a neurotransmitter. One of the main neurotransmitters involved in symptoms of opioid withdrawal.
Thank you.
Yeah. One of the interesting, this is a total aside, but it's making me think of it. One of the really interesting studies that we have going on right now here at Emory is the use of vagal nerve stimulation for treatment of opioid withdrawal. And so vagal nerve stimulation, you put basically a stimulator on the vagus nerve in the neck, and it's an external device, and it's been used to treat PTSD. And so in patients with PTSD, you have this kind of noradrenergic hyperarousal state, and VNS can help to dampen down some of that. And we see it in decreased heart rate and other biomarkers. And so we've been studying the use of VNS in opioid withdrawal to see if we can have the same decrease in noradrenergic response during symptoms of opioid withdrawal that you can see in patients who have PTSD, and that's kind of their elevated baseline. And so we have initial pilot data, and we're actually applying for FDA approval right now with our VNS. So just total aside there. Not in adolescents though. Clonidine, no. So clonidine is not used for seizure disorders. It's quite often used for hypertension. So elevated blood pressure is often where we're using clonidine. And then ADHD. vagal nerve stimulation. So I think you're probably thinking of DBS, deep brain stimulation, and so the implantable rods. All right, here. So going back to some of the age disparities, again, take home points. We don't use medication in adolescents and young adults nearly as much as we should be. So here's some work that my group did. And I want to highlight in this slide, again, those ongoing disparities. So here on the left, you see, and this is using national data from both the TEDS data set, which looks at treatment admissions to publicly subsidized treatment programs across the country. And you can see that the left demonstrates the percent of individuals with opioid use disorder presenting to treatment. So only 3.6% of adolescents with opioid use disorder actually received treatment in 2017. So that was our most recent data based on population prevalence of the expected rates of opioid use disorder in that age group. That's compared to 22% of young adults and 45% of older adults. But of those admitted to a treatment program, only 2% of adolescents with opioid use disorder were identified to be candidates for medication versus 53% of young adults and then 93% of older adults. So young adults referred for medication significantly less often. Adolescents almost never referred for medication, although it is supported by organizations like American Academy of Pediatrics, and it has an FDA approval, 16 and older. So I wanted to know more about the why. And this was a study that we did here in Georgia and is currently in press and should be published soon. But our group ended up distributing an electronic survey to all of the licensed addiction treatment facilities here in Georgia. And the survey had two main sections, and it included questions rated on a Likert scale. So, 1 to 6 of agree or strongly disagree to strongly agree, and then a free response section. And then we conducted a series of one-way ANOVA analyses, and we coded all of the questions, qualitatively coded all the questions and responses. So we had 215 respondents from 73 different treatment facilities. And we found that people were less likely to support the use of medication in adolescents compared to young and older adults, something we kind of already knew. And it's important to highlight here that in every question we asked, we said 16 and older for adolescents, being very clear, buprenorphine is approved, 16 and older. So all of our questions were adolescents, 16 and older. And you can see across the board here some of these differences. And this is just a quick snapshot, but it's basically demonstrating that across the board, any form of medication, methadone, buprenorphine, or naltrexone, they would not use in adolescents. But what we really wanted to know from here is the why. Why wouldn't people be using medications in adolescence? And people were surprisingly eager to give feedback on this topic. And so we had over 1,400 text responses to sort through and code. And what people were highlighting is substantial safety concerns about the use of medication and its potential misuse in adolescents and young adults. Overall, even though naltrexone, and I already presented that, has way less data to support its use in adolescents and young adults compared to buprenorphine, naltrexone was more, which is the opioid antagonist, was more favorable than any other forms of MOUD, medication for opioid use, across all of the age groups. And so that was adolescents, young adults, and older adults. And time again, people highlighted simply it's an opioid antagonist, and the belief that you are not abstinent or truly engaged in recovery if you are taking any type of medication that stimulates those opioid receptors in the brain, even though we have data to suggest otherwise. So here I just really wanted to highlight one of the quotes that we ended up coding. They will become dependent on those as well, taking that dependency into adulthood. I believe that adolescents need to learn to live as adults in a medication-free environment so they can carry those lessons later on in life. I believe they should only be used for detoxification in young adults and adolescents. So what this really is just highlighting is a paternalistic approach to care that is not supported by the evidence base. So again, we really need more advocacy and education, especially here in Georgia, because that's where this study took place. So great question, Chris. Were all of these free text responses from providers themselves or any role within the clinic? So I didn't present the demographic data here. We considered anyone in a clinic as a stakeholder, and then we asked what their role was, and we separated that out. And so we had a mix of prescribers. We also had, the majority were counselors. And so we were really just highlighting here that though even people who are not prescribing have the opportunity to recommend medication and to place a referral and to support their patient in receiving medication. I work with a lot of community providers who are referring patients to me for medication management, and they will just, in front of the patient, tell them, I don't think you should take medication. And that's not just for opioid use, it's for alcohol use. It's across the board. There's a greater acceptability of, treatment of depression, but not necessarily a substance use disorder with medication in this age group. But happy to send that paper around once it's fully published and it has all that demographic data and the breakdown of it. So here, the results really just support an inclusive approach to barrier and stigma reduction, as well as continuing education. One of the questions I hear from parents and from patients is, how long do I have to stay on the medication? And I have found that is a significant barrier, because when you give the response of, I don't know, to a patient, they're less likely to start something. But the truth is, we actually don't know how long patients should stay on medication for opioid use disorder. That's one of NIDA's major goals, and they're currently conducting a large scale study to identify what are those characteristics, when do you know when it's okay to taper a patient off, but we really don't have that data in adolescents. We do know that if you taper in the first 1 to 2 years, that the rate of return to use and overdose is significantly higher. So I'm always recommending at least for a year, and then we make it individualized. And the longer I can maintain someone on medication, the safer they will be. So let's take a quick look at behavioral treatment approaches. So here you see a summary table from a systematic review my team conducted on behavioral therapy for adolescents with opioid use disorder. And we looked through all of the literature going back 20 years, and we found only 3 studies that enrolled subjects ages 12 to 17 and tested the effectiveness of some type of behavioral therapy or counseling. Although some of these initial results were promising, none of the studies here involved a randomized clinical trial. The treatments that we did identify included the adolescent community reinforcement approach, which I'll go into a little more detail on, CBT, so cognitive behavioral therapy, motivational enhancement therapy, and then group therapy with a strong parental or guardian component. But my main take-home point here is that medication is still and should be the mainstay of treatment, with behavioral therapies being ancillary until we get more data to support their effectiveness. But again, treatment retention on medication is abysmally low in this patient population. So, we need to find behavioral therapies that augment medication maintenance. So here I wanted to highlight one of the most common manualized forms of cognitive behavioral therapy used in this patient population called the adolescent community reinforcement approach. It has a mixture of modalities, but it's largely CBT, and it's focused on increasing prosocial behaviors and decreasing substance use. And so some of the procedures within this protocol include relapse prevention, drug refusal, communication skills. They also have functional analyses of substance use behaviors. ACRA, or Adolescent Community Reinforcement Approach, has strong supporting data for the treatment of cannabis use and a wide variety of substances. And it was actually used in one of the largest studies to date in adolescents with SUD called the Cannabis Use Treatment Study. But we really didn't know, did it work in individuals with opioid use disorder? So here I want to highlight two studies. Data for both of these were collected from patients at 54 substance use treatment organizations nationwide that were participating in a national dissemination project that was funded by SAMHSA. So in this first one, Mark Godley, or Dr. Godley, compared the response of adolescents, individuals with primary opioid use, to those who predominantly presented with alcohol or cannabis use. So again, we have an existing evidence base for the use of ACRA in alcohol and cannabis, and we wanted to see in those with opioid use, did it work as well? And what were those differences? And so he found across the board, there were no significant differences in treatment initiation, engagement, or retention. And this, again, is really important because youth with opioid use disorder tend to be very difficult to engage and retain in treatment. So really exciting results here. And we then looked at, in a study of young adults, similar variables, and again, found no differences. And we looked at the substance use outcomes in young adults, ages 18 to 25, through 12 months. And so here you can see that the line with the boxes are opioid use group, and these are young adults. And then the ones with the diamonds are our other group, which would be the MAU, so the marijuana or alcohol group. And we found no significant differences between the opioid group and the marijuana or alcohol groups in alcohol or cannabis use reduction, because the opioid group was using other types of substances pretty significantly. And that opioid and other drug use significantly decreased in the figures C and D for the opioid use group, and maintained some of those declines out through a 12-month period. So these findings suggest that ACRA is not only an effective treatment for cannabis and alcohol, but also for opioid use. Now, what we didn't have enough data on is whether or not the individuals in this behavioral treatment were also receiving medication. There were very few that had reported receiving medication. So the data is encouraging, but again, evidence is for medication. So this could be a way in which we could engage adolescents and young adults in treatment longer. So practically speaking here, and I just want to be cognizant of time, families, again, they can support motivation for change. Often the patient is not presenting necessarily willingly to my clinic, but as long as someone has an investment in treatment, we can increase the external motivators for change, and then hopefully, therefore, increase some of those internal motivators with time and treatment. So when involving family, use their assistance in treatment retention, and then also involve families in decreasing stigma about both medication and then also the use of naloxone. I've had plenty of parents who will tell me, no, my child doesn't need naloxone. They're not addicted to opioids. And I've even had parents tell me that after patients presented with an accidental opioid overdose because of using something laced. So really important about decreasing stigma. I quite often compare naloxone to something like someone in your house has a peanut allergy and you keep an EpiPen at home. let's say for, instance, everybody is potentially allergic to opioids. And this is just one of those rescue measures that everybody should have in every single household. So in summary, youth have been significantly impacted by the opioid overdose epidemic. Our behavioral treatments for this patient population are largely understudied. MOUD is widely underutilized despite having substantial data for its use, at least in individuals ages 16 and older, which again carries that FDA approval for at least buprenorphine. Naltrexone XR, despite people here in Georgia preferring it, is promising and doesn't have quite the data that buprenorphine does, but hopefully we will here in the future. And naloxone is FDA approved for all ages, including pediatric ages and minors. So please give out naloxone to your patients, or at least recommend they go to a pharmacy that might have a standing order. So I just want to quickly shout out to my clinical team, my research team, and some of the funding support that I've received previously, as well as our Addiction Alliance of Georgia, working with the Hazelton Betty Ford Foundation.